Hi, my name is Ozgur, and it's my pleasure to be here tonight with our next episode talking about spine health. Feel free to look at any of our previous talks or future talks on the Hoag website, linking to the YouTube channel, referencing this talk as well as the others. Tonight we're really focusing on spinal stenosis. So spinal stenosis is extremely common. It is used in many different ways if you look it up on the internet, but essentially what it really talks about, or what it means, is compression of the spinal canal. So the nerves get compressed, and it could result in symptoms of pain, numbness, or tingling, usually running down the legs. It could be one side or the other, and it usually is coming from the lumbar spine, so the lower back area. Sometimes it goes along with back pain, and sometimes it doesn't. But basically, when the spinal canal gets narrow, it can pinch on the nerves. So think of the spinal canal as a tunnel, and the spinal cord and nerves are going through that tunnel. Over time, the tunnel can get narrow, sort of like clogged pipes. If those nerves get pinched, it could cause radiating symptoms that start in the lower back and run down the legs. Again, it could be either side or both, the left and the right. So how does somebody know that they have spinal stenosis? Well, usually they have a history that starts a long time ago, and they may have intermittent symptoms of pain, numbness, or tingling starting in the back, running down the leg. Maybe it happens occasionally, but then over time it may happen more frequently and last longer. Because all of us have back pain once in a while. So if you have back pain once in a while, I wouldn't worry about a serious spinal condition. But if it becomes persistent and severe, or lasts for a long time and is going on for weeks and weeks, months become months, longer and longer become years, then you may be having a more serious spinal condition. So most patients with a situation like that will present to their primary doctor, or maybe even urgent care or the emergency room. When they present, they'll get an examination like anything else. The doctor will examine you and try to figure out what's going on. If they suspect that there's some spinal condition, they may order an MRI. The MRIs are aimed to basically give a picture of what's going on inside the body, specifically in the spinal canal. The spinal canal is basically, like we said, is containing the spinal cord or nerves, and that's where if something compresses the nerves, it can cause these radiating symptoms. So if your doctor finds that you have spinal stenosis, they may refer you for treatment. So what are some of the tests they're going to do? They're going to ask you about your symptoms. Are they different when you sit, when you stand, when you walk? What are they looking for? Well, the symptoms are different for spinal stenosis if a patient is in different positions. So for example, if a patient is sitting down like I am, we may have no symptoms at all of spinal stenosis. However, when the patient stands to walk, they may then start having radiating symptoms down the leg. That's pretty classic. In fact, most patients with spinal stenosis will say that when they're seated, they're perfectly fine. But when they stand and walk, they may have radiating symptoms down their legs. Furthermore, you may find that as the symptoms get worse, they may start walking leaning forward. So they're kind of bent forward. This is because anatomically, when our spine is in a flexed position, such as if you bend forward, or if you're sitting in your chair, your spine is actually flexed forward. The spinal canal opens up and the nerves get released, or less compressed than they were before. So that's why patients with spinal stenosis will feel more comfortable, typically if they're seated. Or if they're trying to stand up, they may bend forward, because again, they're trying to relieve the pressure on the nerves. Another very, very classic sign is called a shopping cart sign. What that is basically a patient will lean onto something as if they're leaning on a shopping cart, or they'll actually be leaning on the shopping cart like at the grocery store. So why is that? Again, because they're trying to flex their spine. When you flex your spine, you're opening up the spinal canal and relieving some of the pressure on the nerves. So a shopping cart sign is very, very common. It's a pretty good sign of spinal stenosis. Another thing I'll ask patients sometimes is if you go to the market, even if you're not buying anything or you're buying one item, do you take a shopping cart? The answer is typically yes, if they have spinal stenosis. It's because they want to lean on the cart and they can't comfortably walk around the grocery store without it. Otherwise, patients may have a walker or a wheelchair or something that they're pushing along, because that gives them something to lean on and lean forward. So those are pretty good signs of spinal stenosis. So let's assume that now we suspect that our patient has spinal stenosis. What can we do? Well, unfortunately, a lot of times the family members will tell them to straighten up and stand up taller because the patient's leaning forward. Again, they don't know that they're leaning forward because of the relief of the symptoms. And it's probably painful to stand up straight. Because another classic sign is if a patient kind of tries to reach up high onto a cabinet or shelf, they're actually extending their spine. If you extend your spine, it's actually going to pinch more, as if you're standing up tall. So that's another sign that their symptoms get worse if they're trying to extend or stand up straight. So these patients may have spinal stenosis, and we may suspect it. We may get an MRI to try to confirm that that's what we think they have. Another test and temporary treatment can be an epidural shot. So what is that? That's when we suspect the problem and where we think it's coming from based on the MRI. And we may identify that, oh yeah, here on the MRI you have a spot of severe stenosis. Then we may suggest the patient see a pain specialist to try to inject some steroid into that area of spinal stenosis. So what is that going to do? Well, steroids will help bring down inflammation. It brings down swelling. If we bring down swelling, then effectively the space is more open for the nerves, and the nerves are less compressed. So a patient may feel temporary relief with an epidural steroid injection. So that's a good thing that they may feel relief, but it's not going to be a permanent solution. So it may be a Band-Aid, as we call it, temporary relief that will wear off eventually. So why do an epidural then if it's just a Band-Aid and it wears off? Well, a lot of times we'll do it still as a test, because sometimes the scenario may not be clear. Sometimes your doctors may tell you, well, we don't know where the problem is coming from, whether it's from the spine or somewhere else in the body. Doctors will do their best, but we can't always tell exactly where the problem is coming from. So we may do a test of various sorts. So for the spine, we may do an epidural injection to test if we can identify the source. Now, if the doctor does an epidural steroid injection and the patient feels great for a month and then comes back to my office and says, well, the epidural failed, the test failed. Well, why did it fail? Well, for 4 weeks I felt great, but then now my symptoms are back. Well, I remind them often that, again, the epidural was not a treatment. It's just a temporary a Band-Aid, a temporary test to confirm what we think is going on. In some cases, unfortunately, a patient may have a lot of medical problems and they may not be safe to even consider for surgery. So sometimes the epidural becomes the treatment. And if it lasts for a long time, you may be lucky and it lasts for 6 months. That might be a treatment for you. So a patient may get half a year of relief or 3 months. That's pretty good. And for a patient who may have other medical problems, that may be as good as it gets and may have to repeat it every few months. But for others, it may be something that's very short, maybe a few weeks. And in that case, it's not practical to consider an epidural every few weeks. Nor is it safe in many cases, because steroids can have other side effects. So getting back to the treatments, so an epidural is usually a test. It may be a temporary treatment for a short period of time, but as any other medication, the drug will wear off and eventually the symptoms will return. So let's say we did that test and we confirmed what we thought was going on, and the symptoms went away, patient felt great for 4 weeks, and then the symptoms come back. So then what other options do we have? Sometimes we'll recommend physical therapy as well. That can help strengthen the spine muscles, tighten up the ligaments, give us some core strength to help support our spines. So sometimes that will help symptoms as well. So physical therapy, exercise is a good idea for many patients. Epidural shots sometimes will help with the spinal stenosis or the confirmation of our suspicion of spinal stenosis. The last resort for any spinal treatment is usually surgery. Surgery, rarely do we ever jump right to it because surgery is not 100%, doesn't always work, and surgery has risks and potential complications. So we don't always want to jump to it right away. But for some patients, eventually, the treatments, the conservative options like physical therapy, pain management, injections, epidurals, they may possibly not give a long-term good result. So sometimes we have to consider surgery. So what do we do in surgery? Well, we said earlier that our spinal canal may close down and pinch on the nerves. So a surgical treatment may be to shave some of the bone and make the space open. Open up the space around the nerves and hopefully relieve the pressure and relieve the symptoms. So a decompression is, as a general term, that means we're trying to relieve the pressure on the nerves and open up the space. A lot of times when I operate for spinal stenosis, I'll see that the nerves are just so painfully compressed. Imagine a big boulder on a garden hose. Sometimes that's what the nerve looks like. It's completely smashed. It's a dark reddened color because of the swelling around the nerve. It looks very unhealthy. Sure enough, when I shave down some of the bone and relieve the pressure on the nerve starts to pulsate, which is a good sign because the nerve has spinal fluid in and around it, and it bathes that nerve and keeps it healthy. And so on a healthy nerve, we can see it pulsing with the heartbeat and the pulsation of the spinal fluid around the nerve. So that's a good sign. So when we decompress the nerve and we can see those pulsations, that's actually a really good sign. And usually patients do really well when we accomplish that. So surgery for this condition is usually involving a decompression. So there's many different types, and your doctor may talk to you about different elements of decompression. There's laminectomy, there's laminotomy, foraminotomy. These words may be confusing, but just ask your doctor exactly what they plan to do. They may show you with spine models exactly what they're going to do, where they're going to relieve the pressure, where they're going to remove some bone or ligament, how many levels are involved. Sometimes it's just one, other times it could be 3 or 4 levels. So that's where we want to really focus on what the source of the symptoms are, where the pressure may be, and that's sometimes where we use the epidural. Like let's say there's one level that's really bad, another level it's not that compressed, it's mild or moderate. So sometimes we'll inject in different areas to try to tell exactly where we want to attack the stenosis and perform the surgery. So the surgeon would make a plan on where he or she wants to decompress the spine in the surgery, and then they go and accomplish the task during the surgery, and hopefully a patient comes out relieved of the symptoms. Now some patients are relieved right away and they feel great. They wake up from surgery, they immediately feel cured. They have surgical back pain, but their leg symptoms may be gone. And over time, the surgical pain goes away. But sometimes the nerves heal right away and sometimes they don't. So everybody heals a little bit differently. So don't always compare yourself to your neighbor who had the surgery or somebody else, because everybody's different. Sometimes if the nerve is being compressed for a long time, it may take a long time for the nerves to heal. It may not happen overnight. Other times there could be nerve damage. So if the nerve was under that boulder for a long period of time, there may be elements of that nerve that have suffered permanent nerve damage. So sometimes the majority of your symptoms in your leg may improve, but you may have residual numbness or tingling in your feet or your toes or your heel. So there may be elements that don't go away completely. So talk to your doctor about that and make sure you have kind of a realistic picture that we can't turn back time, we can't make you 20 years younger. We can try to relieve some of the symptoms and help as best we can. But sometimes we make a complete recovery and patients are thrilled, and other times it's partial recovery. Sometimes there are situations where we don't know exactly what's going on and we can't tell. And in those cases, I'm the type of surgeon that will say, I'm sorry, I don't recommend surgery. Because there may be a complex picture where there's a combination of different medical problems going on and one surgery is not going to fix everything. So have an in-depth discussion with your surgeon, whoever it may be. Get multiple opinions and talk about what is the diagnosis, what kind of treatment options do we have. Surgery should generally be the last option. Try other things first and hope that the conservative options work for you. And if they don't and you have to consider surgery, are you a candidate for a minimally invasive surgery? That means we're trying to achieve the surgical result through a small incision to try to preserve the soft tissues, like the muscles, the ligaments, the tendons around that area. Otherwise, a surgeon may make an enormous incision for what can be done through a small cut. And that will mean you have higher potential complications, bleeding, scar tissue, pain, and potential infection. So whenever it can be done smaller, it's better. And that applies for any type of surgery: gallbladder removal, appendectomy, and even spine surgery. So get multiple opinions, talk to different experts about different options, and consider if you may have spinal stenosis, talk to your doctor, see what options you may have. Get the workup, get the tests, because in the end, there are so many patients that I see who are suffering unnecessarily. We can try to relieve some of their symptoms so then they can start walking normally, comfortably, going for long walks, playing with their grandkids, and getting back to work or doing the things that they love. So that's our episode today on spinal stenosis. I hope that's helpful. We're going to take some questions that I think people have asked. And the first question just came in. There's a patient who had a previous lumbar 4-5 slip, had surgery, but is still experiencing some numbness in her leg or hip joint area, and is asking about relief, any type of potential treatment. Is this still healing? Is there permanent damage? And that sort of thing. So, as I mentioned a minute ago, everyone's situation is a little bit different. So in this situation of the viewer who submitted this question, sometimes the spine slips and one vertebral body, like in this case L4 and L5, don't line up the same, and one may be slipped like this. So that happens sometimes. And in some cases, the surgeon will try to realign the spine, put screws and rods and fuse the spine. Sometimes we may leave it the way it is and just decompress the nerves. So in the situation where a patient had surgery and they continue to have some symptoms, it depends on a few things. Number one, what was the diagnosis? What was the initial problem? Was this problem, the numbness, tingling, present before? And if it's the same afterwards, or is this a new problem? So that's important to figure out, because maybe we addressed the initial problem, maybe we didn't completely address it, maybe there's still a problem there. Or if the patient is having pain in the hip, is it coming from the spine, or is it a hip problem, or is it something else called a sacroiliac joint problem? Because all three of those can cause hip pain. So that's why in some of our initial lectures, I talk about diagnosis, that being the key to the treatment. Because if you don't know exactly what the diagnosis is, how can we know the treatment and expect a good result, unless we're gambling with certain treatments or we're just hoping that we hit the right one. So my answer would be, what was the initial diagnosis? What was the treatment? Did the treatment match the diagnosis? And now on a new exam evaluation, maybe a new MRI or X-ray, does it look like the problem was solved? Do we think there's permanent nerve damage from the past? Or maybe there's a different issue going on. Maybe it's a hip problem. If there's ongoing numbness or tingling, sometimes we'll do a test called an EMG. What that is it's a nerve test that a neurologist will do, typically in their office. And they'll basically test the nerves. It's sort of like an electrical test of the nerves, like testing wires. and we're trying to figure out where is the problem of the message going through the nerves. Where is the nerve being damaged or irritated? Is it in the spinal canal? Is it further down along your leg? Is it somewhere else entirely, like in the hip or in the knee or in the shoulder, different places? So an EMG is sometimes helpful to test, why am I still having numbness or tingling, or where is that coming from? So these are considerations that you may want to present. Is your doctor may order a new MRI or X-ray. They may order a nerve test to try to determine why you're still having problems and where it may be coming from. I think we have another question.
Can I treat spinal stenosis naturally?
So the patient, another person is asking, can I treat spinal stenosis naturally? The answer is it kind of depends on how severe the stenosis is. In other words, if it's really, really compressed and tight and there's no room for the nerve, then it's hard to believe that like physical therapy or certain supplements may help that because it's a physical space issue. The nerve takes a certain space, and if the spinal canal is so tight that there's no space for the nerve, it's hard to imagine that certain conservative options may help that nerve. On the other hand, some people have really early stages of stenosis where it may not be that bad. And if we work on weight loss, exercise, core strengthening, posture, these things could help the spinal stenosis. So yes, the answer is sometimes there are natural options that may help, non-operative, conservative options that may be able to treat spinal stenosis successfully. I think we have another question.
I don't know if I understand this. I didn't have.
Okay, the next question is, I didn't have surgery. I saw a chiropractor who used sublation to straighten out back and neck.
She's age 67. I don't know if it's a question.
She is age 67.
Okay. So there's a question about a patient who had some treatment, perhaps with a chiropractor, and did some adjustments, whether in the neck or the lumbar spine. I can tell you in general about chiropractic treatment. I think sometimes people perceive there's a battle between surgeons and chiropractors and things like that. I don't see it as necessarily a battle. I think there's a place for everything. I think sometimes surgery is the right answer and sometimes it's not. Sometimes injections are, sometimes medications, sometimes chiropractors, sometimes physical therapy. So there are different treatments and everybody is different. I think everybody deserves time, an exam, a history, to try to figure out what's going on. And the doctors can do their best to try to make a diagnosis and then recommend some treatments. Now, I've recommended some patients go to a chiropractor. I think it's helpful in some cases. And I believe, just like anything else in life, there are good and bad of everything. Good and bad chiropractors, good and bad surgeons, good and bad teachers, doctors, nurses, trashmen, electricians, everything. I mean, that makes sense. Chiropractors, I think there are some excellent ones, just like physical therapists and physicians. However, it depends on the diagnosis again. Like, what are we treating? What are we trying to do? There are certainly some chiropractors that I think are a little too aggressive. With certain neck conditions, sometimes there's spinal cord compression, and the patient can literally become paralyzed. So their condition may be too severe, where a manipulation or something too aggressive, even sometimes going to a hair salon and getting your neck extended like this, can, in rare cases, cause paralysis. So that's the type of patient I wouldn't send to a physical therapist or a chiropractor to do any type of manipulation of the neck. However, there are some chiropractors that are very excellent and skilled, and they know how to manage the soft tissues of the neck or the lower back. And generally, lower back is of a lower risk for manipulation. In either case, I'm not a fan of big manipulation of anywhere in the spine. I think mild adjustments and work through chiropractors or physical therapists can be helpful. So I think there's a place for that. So it just kind of depends. And like I said, I think there are excellent clinicians out there of physical therapy background, of chiropractic background, pain management, neurology, as well as PM&R, which stands for Physical Medicine and Rehabilitation. So there are different specialists out there. And I think just kind of talk to people, get recommendations from people that you trust, maybe your primary doctor, maybe family members who have had various treatments.
Another question is the doctor familiar with sublation techniques?
Ablation.
They put sublation techniques.
So there's a question coming in if I'm familiar with sublation.
Yeah.
So I'm not sure what sublation is. There is subluxation, there is ablation. So there are different treatments.
Yeah.
So if the question is about subluxation, subluxation is movement of the bones in sort of adjustments. And those are things that sometimes chiropractors will do. If that's the question, then I believe that mild adjustments can sometimes be helpful. Again, I'm not a fan of big adjustments or big manipulations because sometimes things will adjust in a certain way that could be unhealthy. If it's done with exercise and physical therapy and strengthening and stretching over time, that's usually more gentle and better. Now, if the question was about ablation, that's different. So ablation is a treatment that sometimes the pain doctors will do. So what does that mean? Ablation is also known as RFA, radio frequency ablation, and rhizotomy. So those all refer to the same thing. And what that is basically a pain doctor has a suspicion for where pain may be coming from. They may have done an injection and the injection worked for a period of time, and they say, oh, I think we should do an ablation or an RFA or a radio frequency ablation or a rhizotomy. All those terms are basically the same thing. And what that means is to that same spot they may want to put a needle and have x-rays to make sure they are where they want to be. And basically they apply a current. There's something called cold ablation, there is heat ablation, there's a burning. But basically what they're trying to do is create a physical change in that area, kind of a buzzing or burning of that area in different ways. And what that may do is where a chemical like a drug, an injection may temporarily affect that area, numb up that nerve that's causing pain, an ablation may have a more lasting effect. Now the nerve can grow back, but they're basically in some sense trying to burn that tiny nerve ending to make that pain disappear. So that's more in terms of ablation, RFA, rhizotomy, those are the similar terms. Sometimes that's a good treatment. Again, it depends on the certain condition. Sometimes that's a good treatment for certain patients. And I know out there are fans of it and critics of it because some people think of it as a destructive procedure because you're kind of burning something. So there is a little bit of debate there. But again, it depends on the patient because it depends on, are you considering a massive surgery versus an ablation? Because one is safer and easier than the other. Everything may have consequences and risks, but you have to kind of decide per patient what might be in the patient's best interest.
Next question is, can moderate level misalignment heal itself? MRI looks bad, but pain is not severe.
Okay, so that's a good question. Patient is asking, can a moderate amount of misalignment or a slippage, can it correct itself? And the reference is that the MRI may look bad, but the symptoms may be mild. So that's a great point. I'm glad you brought that up because I want to make the point that a lot of times the spine MRI may look bad and the patient may not feel that bad. And this takes me back to an article that was published and a study that was conducted by the Cleveland Clinic. And what they did is they took random people off the street and they had images done of the spine. And then they asked the patients afterwards if they had any symptoms. So essentially, the study showed that there were tons of people out there who had no symptoms, but their MRIs had findings. And if you look at the report, and I'm sure many of you have had MRIs, X-rays, CT scans, and then you get a copy of the report and you read it and you're shocked. Oh my God, this says I have this, this, and this. It sounds very scary, and usually the reports sound terrible because they have medical terminology that we don't understand, and it says severe and moderate and this and that. Don't get too worried. Take it to somebody who knows what all those words mean, and more importantly, they can apply it to you and to see, does this make sense? Is this causing this problem or not? Is this something I should be worried about? Because usually, if you randomly got films, everybody's going to have something. Everyone's going to have some arthritis, some degenerative disc disease. Some people are going to have a bulging disc or a little bit of this or a little bit of that. Don't get too worried. It doesn't all mean that you need surgery and that you're going to become paralyzed. Sometimes surgeons get carried away and really scare their patients into surgery. Most patients do not need surgery. Most patients can be treated with conservative management, with a good level-headed, broad option of weight loss, exercise, sometimes injections, sometimes different types of therapies, conservative options, and then a small subset of those patients may need eventually surgery. There are exceptions. There are rare exceptions where we need to rush to surgery, do something more dramatic. But the majority of patients who have back pain or neck pain don't need surgery. And again, going back to that study, every patient's going to have, the older we get, if you image anyone's spine, we're all going to have some findings. Don't get too worried. If you didn't have findings, then you're not aging. You're not getting older. It's just a matter of fact of getting gray hair and and not being in as good shape as we were when we were 20 years old. So our spines are going to degenerate. Our reports are going to oftentimes sound scary. Don't take it in isolation. Take the report, talk to your doctors, have them examine you, talk to you. If you have no symptoms but you have bad degeneration, then oftentimes I'll say, continue a regular exercise and take care of yourself, try to stay in shape and be active, but don't worry too much, don't lose sleep over it. Again, there are rare exceptions, but don't get carried away by a scary sounding report. Just ask your healthcare providers to help interpret what's going on in the report. I think with that, we've ended our time. Thank you very much for your attention. Remember to look back at the Hoag site for the references on other talks, other spine talks I've given. We have more coming up, but there are other specialties as well where other Hoag professionals are talking about other health concerns as well. Thank you for your time. Have a good night.